Hello everyone, and welcome to the SMART-EST Workshop at AMSSM 2022. We are so grateful that you are joining us. My name is Jacob Stelter, and I am a practicing emergency medicine and sports medicine physician at the North Shore University Health System in the northern suburbs of Chicago. Today we are going to be discussing cardiac and vascular emergencies that you may find yourself confronting when covering sporting events. We are going to review a series of cases, and these cases represent situations that we call halo events. They're high acuity, but they're low opportunity. These are scenarios that you may only encounter a few times throughout your career or potentially even never. However, even the delay of a few seconds in these cases can be the difference between life and death. Hence, it is essential that you review these scenarios on a frequent basis, so that when you encounter them, you are the best prepared to handle the situation in front of you. Case. You are covering a high school basketball game, and one of the players collapses on the court. You know the player is healthy and has not had any recent medical issues. You run out onto the court and you note that he is unresponsive and sweaty, he does not appear to be breathing, and you cannot palpate a pulse. What is your next step? The first thing in any one of these situations, which is much easier said than done, is it's important to remain calm. As the attending physician at this event, you are likely to be the person that everyone's going to be looking to handle this situation. The first and most important step is to make sure that somebody calls EMS. And it's important to actually delegate that to a specific person instead of calling that out aimlessly into the crowd. So delegate someone to contact EMS. Next, you need to call for an AED. An AED is a life-saving device and is often going to come into play in acute cardiac conditions, especially at sporting events. The AED is often held by the athletic trainer, but it may be at a designated location at the arena or the sports complex where the event is occurring. It's important to discuss sudden cardiac arrest, or SCA, in youth. It's the number one killer of student athletes, and it's the number 2 cause of death overall in high school students from a medical cause. More sobering, over 95% of victims die from sudden cardiac arrest. Our out-of-hospital survival is very low. About 95% of these cases are caused from an abnormal cardiac rhythm, most often ventricular fibrillation or ventricular tachycardia is seen here. For every minute that an AED is not used and applied, your survival goes down somewhere around 10%. So it's essential to have this piece of equipment readily available. To utilize an AED, first you want to turn it on, and make sure that you take the pads and you apply them to the bare chest. You do not want these pads applied over the clothes. If the person that you are resuscitating is particularly hairy-chested, you may have one of 2 options. Some AEDs will have a razor so that you can quickly shave the area where the pads will be placed. If that is not available and the pads are not making good contact, most AEDs will have 2 sets of pads. You can use one set of pads to essentially wax the hair off, and then apply the second set of pads to have better contact with the skin. AEDs are designed for use by lay people, and so they are very intuitive. When you open them up, there will be 2 sets of pads, and each pad will have a clear picture on it that tells you where to apply that pad. One of them is going to go to the right upper chest, and the other one will go to the left lower chest, as shown here. Make sure that the pads themselves are actually plugged into the AED. That will not always be pre-set up and is essential for the AED to work properly. While this is all going on, it is very important to also have initiated CPR. As soon as a patient is determined to not have a pulse, CPR should be initiated. While doing CPR, it's important that the patient is on a hard, underlying surface. You also pay attention to the rate at which the compressions are performed. You want to go at least 100 beats per minute, which is about the rate of the Bee Gees song Stayin' Alive. It's important to push deep enough, and you want to go about 2 inches. One of the other most essential parts of CPR is to allow for sufficient recoil, meaning that you allow the chest to return to its natural position in between compressions. Not doing this will not allow the blood to return to the heart in a sufficient manner and will reduce the ejection fraction, or the amount of blood that's being pumped out of the heart. There's always a question about whether to initiate rescue breathing. Current recommendations for bystanders, meaning non-medically trained people, is to only do chest compressions and to not do rescue breathing. Studies have actually shown that doing rescue breathing with compressions by bystanders causes a reduced survival. It's thought to be because of the fact that bystanders are going to be more hesitant about performing mouth-to-mouth resuscitation or rescue breathing, and they are also likely to unnecessarily delay chest compressions while providing those breaths. If you are a healthcare professional and you are responding to this situation, you absolutely can incorporate rescue breathing, and that would be at a ratio of about 30 compressions to 2 breaths. Some studies have shown a minimal increase in survival when incorporating rescue breathing. However, it is most important to minimize compression interruptions, and if you do not have appropriate equipment with you to perform rescue breaths, do hands-only CPR and do continuous chest compressions. Now let's return. So in this scenario, the head coach started chest compressions and you applied the AED. When the AED starts to analyze, it's important that nobody be touching the patient. The AED advises shock advised, and you administer the shock. Now, a few notes on administering a shock. When the shock is being advised, it is very important that no one be touching the patient. It is also important that the patient not be in a pool of standing water. They need to be removed from that area if possible, as that will transmit electricity and potentially could cause an electrocution of anyone who may be touching that pool of water. As soon as a shock is administered, it's important to restart CPR. In this situation, after the shock is delivered, the patient begins to spontaneously breathe. If you notice that while you're performing CPR, you should stop CPR and check a pulse. In this scenario, the patient had a pulse, and CPR was held. Shortly thereafter, EMS arrived, and he was taken to a local hospital. Let's review another case. Again, you're covering a basketball game when another senior collapses on the court. In this situation, you know that the athlete is healthy and does not have any medical problems. You run out to the court to assess her, and you see that she is responsive, but she has labored breathing. She's tachycardic and tachypnic when you assess her vital signs. What is your next move at this situation? First, you want to assess the athlete for other potential signs that may clue you into the diagnosis. In this patient, you note that her trachea seems to be deviating a little bit to the left, and her neck veins seem to be distended. You perform a poor man's blood pressure check by assessing the strength of the peripheral pulse, and you note that her pulse is weak and thready, cluing you into the fact that she's likely hypotensive. If you happen to have a stethoscope, you can listen to the heart and lungs, and in this case, you do, and you note that there aren't any breath sounds on the right side. This constellation together, so you have descended neck veins, absent lung sounds on one side of the thorax, you've got hypotension and tachypnea, all of those point to a collapsed lung, or a pneumothorax. Specifically in this situation, we would term this to be a tension pneumothorax, given the fact that there is hypotension, tachycardia, and hemodynamic compromise. This is a life-threatening condition and needs to be acted upon immediately. Here's an x-ray that demonstrates what we are treating. However, At the sideline, you're obviously not going to have this technology available, but this just demonstrates the physiology or pathophysiology of what's occurring. It's important to relieve that tension. If that tension is not relieved, the patient will go into cardiac arrest. Again, as in any scenario, it's important that you've already activated EMS, as they need to be on the way in order to assist this patient to the hospital in the event that your efforts are not successful. You want to take the biggest angiocatheter that you have available, and you want to insert it into the chest on the right side. You have two specific locations where this can be inserted. You can go in the mid-clavicular line anterior on the patient in the second intercostal space on the affected side. The other place that you can go is in the anterior axillary line at about the fourth or fifth intercostal space. Both of these areas will provide you access into the pleural space and should relieve the pressure. It's important that with the angiocatheter, after you've inserted it, that you remove the needle, but that you keep the plastic catheter in place. This will allow a conduit for that built-up air to dissipate. This will help to stabilize the patient. However, they still are going to need a chest tube placed, as this is just a temporary measure. Here's a diagram showing where exactly to insert the needle. In this situation, you correctly diagnose a tension pneumothorax and you insert a needle into the right side of her chest. There's an immediate rush of air and the patient's vital signs improve. EMS arrives and she's taken to the hospital. Let's review a third case. In this case, you're covering a baseball game and your player who's up for bat takes a 93-mile-an-hour fastball off of the chest right in the middle of the game. He immediately collapses in the batter's box and is motionless. You are familiar with the team and everyone's medical problems, and you know that this patient does not have any baseline medical history or issues. To assess the patient, you see that he's not breathing and he doesn't have a pulse. What is the most likely diagnosis? And as you are right now to assess this patient, what should you be grabbing? A situation like this is most likely commotio cordis. This is when is caused by sudden cardiac arrest that's triggered by a direct, blunt chest trauma. Most often affected are pediatric patients, and it's thought that this is because of their increased chest wall compliance, which allows more force to be administered to the heart. It's common in sports that have fast-moving, compact projectiles such as baseball and lacrosse, as well as martial arts. Protective equipment has not been shown to reduce the incidence of commotio cordis. And typically we see this when the projectile is going 40 miles an hour or faster. Again, the key to survival here is early time AED. The pathophysiology of commotio cordis is that if the impact occurs in between the QRS complex and the T wave, specifically the upstroke of that T wave, you get an R on T phenomenon that can lead to ventricular fibrillation. Again, as we discussed, an AED is going to be the reversal agent. So you head out to the box, you have your AED and your athletic trainer with you. Your athletic trainer initiates CPR, and similar to as we discussed before, you apply the AED. A shock is advised. In this case, you administer the shock, and there is no return of spontaneous circulation. So you continue CPR. You then analyze the rhythm again, and the AED recommends a second shock. After that second shock, in this case, you restore spontaneous circulation and the patient's taken off to the hospital. That concludes our discussion about cardiac and pulmonary emergencies that you may encounter while covering sporting events. To conclude this presentation today, I would also like to discuss with you about the use of tourniquets, as we discuss some vascular emergencies that you may potentially encounter. Tourniquets were initially developed by the military to reduce acute hemorrhage, and they are considered to be life-saving devices. There's definitely a significant survival benefit to their use both pre-hospital and before the onset of hemorrhagic shock. We know that overall early application of tourniquets is life-saving. And there are definitely sporting events where you may need to use tourniquets. As we think about femur fractures, specifically open femur fractures that may have severed the femoral artery. Hockey games where you can have multiple different lacerations from skates. As we think of projectile sports or javelin throwing, or even, sadly, a mass casualty event. Here's a basic algorithm to help guide us as we're managing bleeding. The first and most important step to managing bleeding is the application of direct pressure to the wound. If that's effective and stops the bleeding, you can stop there until the patient is brought to more definitive care. If you're unable to apply enough direct pressure to stop the bleeding, you need to consider two other options. If this is an extremity wound that's amenable to a tourniquet should be applied immediately. If it is a wound that's not amenable to a tourniquet, such as a junctional wound, thinking about a wound to the inguinal region, the area should be packed with hemostatic gauze or trauma gauze if you have that available. There are 3 different types of tourniquets, although most of them essentially function the same way. It's important to remember that improvised tourniquets are not nearly as effective as commercial tourniquets, and hence it is definitely worth the investment to carry 1 or 2 tourniquets with you in your sideline bag at all of your events. Most of them have the same features. They have a time strap, they have a single routing buckle, they have a thicker windlass rod in order to turn the tourniquet itself, and then they have a bilateral entry windlass lock that keeps the lock in place. This allows for even circumferential pressure to be delivered throughout the tourniquet device. There's also a wider version that's available, and there's also a canine version which comes into play especially with police dogs and SWAT teams. This is another type of tourniquet device that's a little bit cheaper and easier to use. It's called the SWAT tourniquet. And this occurs where you stretch it, and as shown in the figure, and wrap it around the extremity and then tuck it into place. Hemostasis can be a little bit more difficult to attain with this, although it is an option if you have it. When you're applying the tourniquet, it's important to remember that you want to put it as proximal as possible on the extremity. It can be applied over clothing, but make sure there's nothing in pockets if you are applying it over a pocket, as that will disrupt the circumferential pressure that the tourniquet is trying to achieve. Also, do not place it across a joint, as it can cause trauma from the pressure. Tighten the tourniquet until the bleeding stops and you do not have a pulse, more distal to where the tourniquet has been placed. If you are still feeling a pulse despite tightening that tourniquet as tight as possible, to add a second one more proximal to the first one. It's important to remember that you want to place these tourniquets as high up on the extremity as possible and as tight as possible. It's also important to remember to document the time of placement. This can be done in a few ways. One is that if you have a marker, you can document it actually by writing on the patient, on their arm, on their forehead. Most commercial tourniquets will also have a time area on the tourniquet itself, note of the time. It's important to remember that these tourniquets are life-saving devices. There are no reports of amputations caused by a tourniquet left in place for less than 2 hours. There is a small risk of a transient nerve palsy. However, these are life-saving instruments, and they need to be used early to prevent exsanguination and death. And so the risk of a transient nerve palsy is definitely something that does not even need to be considered in these situations when you're at a life or death patient situation. And that concludes our discussion today about cardiac and vascular emergencies. Some key takeaway points that we want you to walk away with is when providing medical coverage, make sure that you know where the AED is and how to use it. While securing the AED and getting it in place, make sure that you are performing CPR at either a continuous rate of over 100 beats per minute or a 30-2 ratio if you have the equipment and decide to perform rescue breaths. Make sure that you're minimizing interruptions to compressions in order to maximize your survival. Sudden collapse, absent breath sounds, hypotension, tachycardia are all signs of a tension pneumothorax and need immediate needle decompression. Blunt trauma to the chest can lead to cardiac arrest from an RNT phenomenon, most likely causing ventricular fibrillation, and this is something that's called commotio cordis. And treatment, remember, is early application of AED and delivering of a shock. And remember, tourniquets are limb and life-saving. Place them high and tight, as proximal as you can to control bleeding. And remember to keep them in place until the patient reaches definitive care. Thank you so much, and we're glad that you could join us.